Ladies and gentlemen, welcome back to part 2 of our podcast with Dr. Deepthi Vilasini. We're honored to have Dr. Deepthi with us today. She's a highly experienced medical oncologist where she currently serves in the Department of Hematology and Oncology at Sheikh Shakhbout Medical City in Abu Dhabi. Her expertise spans a wide range of cancer cases, including solid tumor malignancies and hematological malignancies, excluding acute leukemia. Now, in the spirit of Breast Cancer Awareness Month, we continue our exploration of this critical topic by delving into the treatment of breast cancer. Dr. Deepthi, thank you so much for joining us again.
Thank you again.
Now, without further delay, let's begin with our podcast. Dr. Deepthi, what are the main treatments used for breast cancer, and how did doctors decide which one is best for a patient?
Thank you, Niga. That's an important and good question. So, historically, we had three most important pillars of oncology care, which would be surgery, radiation, and chemotherapy. So, and in the current era, we have added on a lot of treatment modalities into this three modalities as well. So there are plenty of more treatment options at the moment. But having said that, these three still remains the pillars of treatment for breast cancer care, if you would ask me. So what do we have extra now? We have tumor type directed treatments such as monoclonal antibodies, you have immunotherapy, you have anti-estrogens, you have some molecules such as CDK4 and 6 inhibitors, you have PARP inhibitors. So how do we decide what is best for a patient? So this treatment is directed by stage of the tumor, age and performance status of the patient, the tumor type. The tumor type, when I say tumor type, in breast cancer, we usually have like four important types. You look at three factors. You look at whether the estrogen and progesterone receptors are positive or negative. You look at whether a HER2 gene, which is an oncogene, whether it is positive or negative. And you can classify breast cancer into broadly four types according to whether it's HER2 positive. If it's like ER or PR positive, which is estrogen and progesterone receptor, then it would be hormone receptor positive. Then if you have all of the three negative, then you have a triple negative disease. Or if you have HER2 positive along with estrogen and progesterone receptor positive, it would be triple positive. So my treatment would primarily be directed by this tumor type. And as I said earlier, it would also be directed by the stage of the tumor and the age and performance status of the patient. I can give you examples for the same as well. So all early stage patients will usually have surgery. So stage 1 to 3, there is always a role for surgery. So we prefer lumpectomy. Lumpectomy means we prefer to just take the breast cancer mass out of the breast instead of removing the whole breast, which is called mastectomy. So this is the preferred modality, except in some subtypes such as inflammatory breast cancer, where you have like widespread skin involvement as well. So for multifocal multicentric diseases, if there is any contraindication to radiation, also we would prefer mastectomy. Why this is? Because if you have a lumpectomy, which is called breast conservation surgery, then it would invariably be followed by radiation, which would complete the breast conservation treatment. So if there is a contraindication to radiation, such as with some connective tissue disorders, then obviously you cannot have radiation and it would be suboptimal to just have lumpectomy. So other than these unusual situations, all patients usually we prefer a lumpectomy. And most tumors, especially more than 0.5 to 1 centimeter, will have chemotherapy, especially HER2 positive and triple negative tumors. Now, when I say chemotherapy, chemotherapy is a large umbrella under which a number of medicines are used. So it could, what we basically is doing is to block the cell's ability to divide, because we know that cancer is division of uncontrolled proliferation of cells. So we are basically blocking the cell's ability to divide. That is where we use chemotherapy drugs. And these drugs usually, they either go with direct DNA damage or slow down or stop DNA synthesis by multiple mechanisms, which is outside the scope of our podcast today. But this is basically what chemotherapy does. And now if you have a hormone receptor positive patients, especially low risk tumors such as node negative tumors, we have currently treatments available like like assessing their genomic risk. How risky is this patient to have a disease recurrence later on? So this is called, there are multiple genomic risk assays available. The commonly used one is called Oncotype DX. And the beauty of this is that if you find that your patient, especially with node negative patients, if they're low risk, they can totally avoid chemotherapy and they can have their treatment after surgery with only hormonal management, which would be anti-estrogens. So again, if a patient has a HER2 positive type, they would have something called a monoclonal antibody, which is an anti-HER2 treatment. So what it does is blocks the HER2 gene. So so you would have like treatment before or after surgery, which would have this anti-HER2 monoclonal antibody incorporated into the treatment as well. And if they are triple positive, as I said, if they are estrogen and progesterone receptor positive also, then they would have their treatment with adjuvant anti-estrogens after the anti-HER2 directed treatment as well. So I think there are some two words I would elaborate here. So there is something called neoadjuvant and adjuvant. So neoadjuvant is anything that you give before your definitive treatment. So for breast cancer, if you consider surgery as definitive treatment, anything that you give before surgery would be neoadjuvant, and anything that you give after surgery would be adjuvant. So anything before surgery is neoadjuvant, anything after surgery is adjuvant. So, and stage 4 is a totally different um, different area, and we also, but the same idea and pattern is followed. So you usually have tumor typed according to the HER2 positivity, estrogen receptor positive or progesterone receptor positive, and then you incorporate newer treatment modalities also. For example, in metastatic estrogen receptor positive patient, there is a molecule available called CDK4 and 6 inhibitors, which you can add along with their anti-estrogens for more survival benefit. And also, there is currently role for PARP inhibitors, which are used for BRCA mutated patients as adjuvant and also in stage 4 disease. So these are all like dependent upon the pathology report and the further testing that we do on the biopsy, which will let me know what type of treatment to give for what kind of patients. And as I said, the most important things would be stage, tumor type, performance status, and the age. Because some of these patients, even when you know that a particular treatment is best for them, they may not be in a situation to have that because of a poor performance status. So then we'll have to tailor our treatments according to what the patient can tolerate as well. So that's how we usually go ahead with our treatment plan. I hope it's clear.
Thank you so much, Dr. Deepthi, for giving us a very detailed answer on the main treatments used for breast cancer. Now, when it comes to tailoring these treatment plans based on type and stage of breast cancer, how does tailoring these treatment plans improve patients' chance of getting better?
All right. So why do we want to tailor treatment is because, as I just mentioned before, so my treatment for a patient or the breast cancer treatment is directed, I said, by the tumor type and by the stage. So why do you want to like tailor treatment in that way is because you can give the most beneficial treatment scientifically, which will help cure the disease in an early stage and control the disease in a late stage metastatic disease. And the best treatment would be guided by the tumor type and by the stage. So tumor typing is paramount, and also other than the regular pathology testing that we usually do, there are other varieties of testing available which are called next generation sequencing, wherein we can assess the tumor for any actionable mutations, which we say. Actionable mutation means a patient may have a particular mutation positive in the tumor, and I may have a drug which can block that mutation or which can go work against the mutation. Then those mutations are called as actionable mutations. So a next generation sequencing will give me an idea about how to what treatment modality to use for a patient once you exhaust all your available treatments as well. So these are all like, because that particular mutation will be present in that particular tumor type, it may not be the same with another patient. So that would give that particular patient the maximum benefit. And especially for stage 4 cancers, where you usually cannot cure the patient, but you want to like control the disease and keep the patient in remission as much as possible. These forms of treatments, these forms of investigations actually helps us to give them the most appropriate treatment for the patient. And also another term that we are seeing, hearing a lot these days and is coming up these days is de-escalation of treatment. So when you have a particular treatment which is most beneficial for a particular tumor type, you also think about de-escalating the treatment so that it causes less side effects as well. So I can explain that with an example. So for HER2 positive patients, usually as an adjuvant treatment, if you remember what's adjuvant, that's given after the surgery. We usually had a chemotherapy protocol which would include multiple chemotherapy drugs. But then there were some studies which were done on that. And currently, for very small risk, lower risk patients, like less than 3 centimeter with node negative, for a HER2 positive patient, as an adjuvant treatment, there is something called APT protocol, which is just one chemotherapy drug with 2 monoclonal antibodies instead of a multiple chemotherapy combinations. So this is something which I personally see as a very good uh, indication for further future innovations as well, because the patient, definitely for the patient, this means good news, because you are left with a lesser toxic treatment, more, and it gets the treatment gets completed in a more faster fashion as well, and you can de-escalate the treatment, but still you're giving them the best benefit as well. And for a hospital perspective, or for the society as the perspective also, there is definitely less overall cost as well. So I would say that tailoring the treatment to the particular tumor type can help in all of these ways.
Thank you so much, Dr. Deepthi. This definitely underscores the importance of personalized medicine in oncology.
That's right.
Now, moving on to our next question. What are some common side effects and long-term effects of breast cancer treatments that patients and doctors should be mindful of?
That's a very good question, Niga. So, yeah, that's the side effects is definitely related to the treatment modalities. If we can look at it, we can look at it like an early side effect and late side effects. So I would say we can start with surgery, where the immediate complication that you would expect is delay in wound healing due to multiple reasons, comorbid conditions, seroma formation, which can be quite cumbersome for our patients. And then you can have long-term side effects such as numbness to the area of where you had surgery, and lymphedema post X-ray dissection as well. When you come to chemotherapy, as I said, chemotherapy is a large umbrella under which you can have multiple drugs. So each drug can have a particular side effect profile. But most commonly that you would see, and which you would be really wary of with all chemotherapy agents, is myelosuppression. So what that means is, myelosuppression would mean suppression of your myeloid cells. So it could be pancytopenia, it could be like anemia, leukopenia, and thrombocytopenia, of which we are most concerned about the leukopenia, especially neutropenia, which can which can be a potential risk factor for febrile neutropenia, sepsis, etc. So the risk of myelosuppression will differ with each chemotherapy modalities. Some will have very low risk, some will have high risk. And if you anticipate a high risk myelosuppressive chemotherapy, we have granulocyte colony stimulating factors which can prevent the risk of neutropenia as well at the moment. And then you have the regular side effects, nausea, vomiting, which actually, fortunately, we have wonderful drugs and most of our patients are okay on that front. There are some medications which can cause allergic reactions, immediate mostly, alopecia, mucositis, hand and foot dryness or peeling of skin, nail changes, including paronychia, etc. And then you have late complications like cardiac complications, especially with anthracycline-based chemotherapy, which can cause cardiomyopathy, pulmonary fibrosis, which can be seen with some drugs such as bleomycin, infertility with certain drugs, persistent neuropathy with drugs such as oxaliplatin, renal damage, which could be permanent very rarely in some patients with platinum. And then when you come to radiation, you have immediate reactions such as mucositis or skin peeling of the radiation is basically a localized treatment. So any effects or side effects which will be limited to the area that is being irradiated. So you would have like a mucositis if it's a head and neck area, which involves mucosa of the oral cavity. You can have skin peeling, skin redness, erythema, etc. if it's on other parts of the body. And you also can have late term side effects such as skin fibrosis, lymphedema, cardiac issues such as coronary artery disease, cardiomyopathy, and very rarely second malignancies also. Now we come to the newer modalities of treatment such as monoclonal antibodies. The commonly used is Herceptin, and Herceptin is a monoclonal antibody against anti-HER2. There are a variety of anti-HER2 monoclonal antibodies, including something called antibody drug conjugates these days that we use. All of these can cause cardiac failure. Usually, this is not very common, but usually, and it's reversible as well. Rarely you can have myelosuppression with these combinations, and antibody drug conjugates, which I just elaborated right now, they can cause pneumonitis, neuropathy, myelosuppression, etc. And the other variety of drugs that we have, the PARP inhibitors, they can cause myelosuppression, especially anemia, nausea, vomiting, fatigue. Rarely acute AMLs have been reported as also. Now, when you come to immunotherapy drugs, they usually cause endocrine abnormalities, but they can cause pneumonitis, colitis, hepatitis, etc. Even though those are fortunately rarer than the other common side effects such as endocrine abnormalities. Usually we see hypothyroidism. So that would be the common side effects that we see. But the point to be remembered is it can differ with the type of treatment that you use, and also the comorbid conditions and the general condition of the patient, and also the type of treatment such as radiation, surgery, or chemotherapy that can your side effects will vary with these treatments. Yeah, that's it.
Now, moving on to our final question of the day. With new treatments like targeted therapies and immunotherapies, how have breast cancer treatment plans changed and how do they benefit the patients?
Thank you, Nigar, for that question. So our aim basically is to improve the survival for our patients. Basically, that's the aim with all new treatments. So in earlier stage, you look at cure with less toxicity. In late stages, especially stage 4 metastatic disease, what you're aiming to do is to keep our patients in remission as much as possible, but also making sure that their quality of life is enabled so that they can go ahead with a near normal life as well. So in a stage 4 disease, the aim hopefully will be to make it a chronic disease with less side effects. So how has the newer treatments helped us is because they have changed the landscape of treatment totally, because the survival is definitely better than what it used to be. So there were like multiple meta-analysis which looked into it, which gave us a sign that I can just elaborate this example for you. So there were meta-analysis which have shown that survival improvement for metastatic stage 4 CA breast, there was no survival improvement between 1980 and 1990. When it came to 1990 to 2010, that decade, you had a median overall survival of around 21 to 30 months. And when it comes to the present era, it's even up to 33 to 60 months at present. So what does that mean is these are patients, the median survival, when I say median survival, what it means is that 50% of the patients will be still alive at, at that 5-year endpoint. So what that means is, earlier on, we could not have imagined a stage 4 breast cancer patient living for 5 years, still on treatment or still in remission. So this is what exactly newer treatments has helped us to do. So we are, as I said, we are aiming to make these patients live for longer, keep them in remission, still have a good quality of life, so that life still goes on. So I would say, especially for stage 4 cancers, newer treatments has been path breaking, and it has helped many a patient continue their life near normal. So that's one area I would say how patients have benefited from these treatments. So we have multiple options. That's what I mean. So it's not that the patient may be on a particular drug and going on for 3, 4, 5 years, but it's just that you have multiple drugs available which you can use as second, third line, which can make the patient continue in remission and thereby give them a chance at more having more definitely survival benefit than before.
As we wrap up this insightful episode, a heartfelt thank you to Dr. Deepthi for actively participating in our Breast Cancer Awareness Month campaign. Dr. Deepthi, your contributions and expertise have been very instrumental in raising awareness about this crucial topic. Thank you very much for joining us.
You're welcome, and thank you again for the invite.
Thank you so much. I'm looking forward to many more interesting podcasts together.
Sure, hopefully, yes.
And to our fantastic audience, we appreciate your active engagement. And if you have found this discussion valuable, remember to hit the like button and hit the subscribe button. Your actions make a real impact on our MedSynapse platform. Stay informed, stay healthy, and until next time, goodbye.